Can you see the screen?
Yes, please, we can.
All right, so today we are going to look at the esophagus and the stomach, if time allows. And I asked you last time to read about these two digestive structures. And we're going to start right away. So the esophagus is very important in the body. It's one of the structures of the upper GI, and it's relevant in the swallowing reflex. It's a passageway for food from the throat down to the stomach. And it's a muscular tube. It's made up of muscles, as you are going to see. Muscles that allow movement of food substances, to be specific, movement of the bolus and liquids down to the stomach. So it's important to first appreciate how it forms, because this can guide us as we go on. So you can see in this image is showing you a growing embryo at around 4 weeks of development. And around this time, of course, you can appreciate a few things. This is the cranial end, this is the caudal end. What you see in yellow is what we call the primitive gut, okay, or the underdeveloped gut, the developing gut, okay. And last time I told you that this gut, we divide it into 3. The cranial end is called the, who can remind us? How do we call the cranial end of the primitive gut? Yes, it is called? How do we call the cranial end of the developing gut? Yes, Agnes, how did we call it last time?
The foregut.
The foregut. Then the mid portion that is herniating. This is the midgut. Then the caudal end is the hindgut. So around the 4th week of development, the foregut is going to undergo differentiation to give rise to several structures. And among these structures, you can see the pharynx, okay? And of course, below that, we should form the stomach, the esophagus, okay? And at the same time, from this part of the foregut, on the anterior aspect, there is always development of what we call the respiratory diverticulum, or you can call it the tracheobronchial diverticulum, an extension that will keep on growing to give rise to the respiratory system structures. Okay, this is going to form on the anterior ventral aspect of the foregut. So what we see here, around that time, 4th week of development, we are seeing the foregut that is developing. This is the upper part of the foregut, this portion that will give rise to the pharynx, okay, and the esophagus. So usually this upper part of the foregut, from the ventral aspect, there is always formation of what we call the tracheobronchial diverticulum, or you can call it the respiratory bud, okay. This structure, it's what is going to keep on growing to give rise to the bronchial buds, that will keep on differentiating to form the bronchial tree and the lungs, okay. So normally this tracheobronchodiverticulum, after its formation, it has to be separated from the foregut, okay? Because we know that normally the respiratory system structures, they are not supposed to be united with the digestive system structures. This is the foregut. It's going to become the this portion is going to become the pharynx proximally, and then the esophagus distally. So these structures have to be completely separated from the respiratory system structures, and that complete separation normally it's going to be attained because of the formation of what we call the tracheoesophageal septum. Normally this septum it's going to form to separate your developing respiratory structures from the digestive structures. So basically it's just a mesodermal tissue that is growing, and it begins as a ridge, and these two ridges grow towards each other, and once they meet they form what we call the tracheoesophageal septum. This septum completely separates the developing respiratory structures from the structures that are going to be coming from the foregut structures, for example the esophagus. These two are going to be separated by what we are calling the tracheoesophageal septum. This is mesodermal tissue growing, separating the respiratory structures from the digestive structures. Okay, so complete separation has to be attained by the end of the 5th week of development. So, as I said, normally these two structures have to be separated. The esophagus has to be completely separated from the trachea with the help of that septum. But of course, in some cases, normal development is never fully attained, and abnormalities can arise. So abnormalities related to this embryological development can be categorized into 5. We have a type A abnormality up to type E. So in type A, what are we seeing? We are seeing a normally developing trachea, not in any way communicating to the esophagus, but this esophagus, the proximal end is not uniting with the distal end. There is what we call atresia. Atresia means incomplete development. The esophagus is incompletely developed. Okay, these two are not continuous with each other. We call that type A anomaly. And here basically we have isolated esophageal atresia. Isolated meaning that the problem is only the esophageal atresia. There's no any issue with the trachea. Then in type B we are seeing that there is an atresia with a fistula. What does the word fistula mean? What does the word fistula mean? Anyone to tell us? Yes, Pearson?
Okay, a fistula is a communication between two hollow organs.
Thank you. Communication between two hollow organs, that's a fistula. So here we are seeing the proximal part of the esophagus is abnormally communicating with the trachea. The distal part is incompletely developed. So there is an atresia with a proximal fistula. Okay, a proximal tracheoesophageal fistula. Alright, then in type C, we are seeing a proximal esophageal atresia. Here it was distal, but here now it's proximal. and we are seeing the distal part of the esophagus abnormally fusing with the trachea. So this is an atresia. This is a proximal esophageal atresia with distal tracheoesophageal fistula. Okay, this is the commonest variety, the commonest abnormality. Most kids are going to be presenting with this type of abnormality. It's present in about 85% of the neonates. In type D, we are seeing, of course, the esophagus is not continuous. The proximal end is not continuous with the distal end, so there's an atresia with a double fistula. Both the proximal and the distal ends are abnormally fusing with the trachea. Then in type E, we are seeing there is continuity between the proximal and the distal ends of the esophagus, so there is no atresia, but we are seeing that this normally formed esophagus is abnormally fusing with the trachea. So here we are only seeing a tracheoesophageal fistula. Okay, this can sometimes be called an H-type kind of fistula, because it's still forming an H, trachea, the fistula, and then this side the esophagus. This is type E, but all in all, this is the most common one, because it's present in most of the neonates. This abnormality, we said it's the most common one. The proximal esophageal atresia with the distal tracheoesophageal fistula is the most common one, and usually it's going to result into complications during the gestation period. Okay, so we know that normally the growing fetus has to swallow the amniotic fluid. This amniotic fluid is normally found in the amniotic sac. It has to be swallowed by this growing fetus. That fluid has got nutrients, it has got growth factors that are supposed to circulate throughout the body to allow normal development of several structures of the growing fetus. And then later on, that amniotic fluid has to be excreted in form of urine, and that urine is deposited into this very sac. So normally there is formation of the fluid, and there's continuous absorption and excretion of that fluid back into the sac where it came from. So it's a normal process, it is continuous, it has to happen. It has to happen. So in scenarios like this growing fetus is not in position to swallow. So what will happen? The fluid is going to accumulate in the amniotic sac, and that complication is called polyhydramnios. Polyhydramnios, excess fluid within the amniotic sac or the amniotic cavity. And this is going to present in about 30% of it's going to be a complication in about 30% of neonates having this abnormality. And such fetuses exposed to this complication usually may be born before the end of gestation. They may be premature labor, premature birth, because this excess fluid over time creates pressure onto the placental membranes and can induce premature labor. Okay, can induce premature contractions, and this baby may be born before the end of the gestation period. So this is the outcome of this complication that is going to be coming in as a result of this abnormality. Okay, so now usually this abnormality is diagnosed after birth, and we can see how or what can be seen radiographically when these young ones are examined by X-ray. So up here we are seeing a child with anatresia, a proximal esophageal atresia, in this image up here. Hope you can all see it, though it's inverted, but you can see a proximal esophageal atresia, and also you can see that the lower part of the esophagus is abnormally fusing with the trachea. So there is a proximal esophageal atresia with a distal tracheoesophageal fistula. So in such abnormalities, it will be very hard to pass feeding tubes down into the GI tract or down into the alimentary canal of these young ones. Usually there is always need to feed these young ones. Let's say if there are some complications after births, these young ones have to be fed using these feeding tubes. Okay, but in such an abnormality, it will be very hard to pass a feeding tube down along the alimentary canal because there is some atresia, there is some underdevelopment of the esophagus, so the tube cannot go through. Okay, this is called a nasogastric tube. So actually this can guide during the radiographic examination of these young ones. You can see our tube there. Once it's inserted into the alimentary canal, it's not going to continue downwards. You can see it is looping around itself. It's inserted, and because there is no continuity, it will just loop around. So that confirms that there is an esophageal atresia. Okay, and that's what can be appreciated in this first image. In this first image, there is just an isolated esophageal atresia. There is no fistula, but this side there's a fistula, and I'm going to explain why. So usually whenever there is a fistula, like as you see in this small image down here, whenever there is a fistula, it means that whenever you're taking the air from the trachea can easily enter into the stomach, and of course this air will continue down along the intestines. So this gas usually appears dark on X-ray, and kids with a fistula always present with so much gas within the stomach and the intestines, and that can be confirmed here. So you can see once you pass a nasogastric tube into the alimentary canal of these young ones, because there is an atresia, okay, this tube is not going to continue downwards, it's going to just loop around itself because there is no continuity. That only confirms that there is an esophageal atresia, just as we confirmed it here. But because of also the presence of gas within the stomach and excess gas in the intestines, this can be an indication that there is a tracheoesophageal fistula, okay, that is allowing the air from the airway to enter into the alimentary canal. So that is something that can guide you in concluding that this kid is suffering from an esophageal atresia, proximal esophageal atresia with a distal tracheoesophageal fistula. Okay. Of course, thorough examination can be carried out to really confirm this. This can be further be seen on X-ray, though this image is not clear, but once this is seen, of course, more projections can be taken to confirm, to really see it on imaging. But this only can guide you in confirming that there is a proximal esophageal atresia with a distal tracheal esophageal fistula. Okay. We said that the tracheoesophageal septum, it's basically a structure that is going to be mesodermal or in origin. Just mesodermal tissue growing to separate the airway from the alimentary canal. Okay. And usually, whenever kids present with esophageal atresia and the fistula, in most cases, in those young ones, there are some added or some other associated abnormalities, because there are many other structures that are going to arise from the mesodermal tissue. And whenever there are such abnormalities, there's a very high chance that there are many other abnormalities in structures that are supposed to be given rise by mesoderm. For example, bones, okay, the heart, okay, the limbs, these come from mesoderm. The renal system, all these come from the mesoderm. So in most cases, whenever there is an esophageal atresia and a fistula, there is a very high chance that this kid may be also having a cardiac anomaly. This kid may be having a renal anomaly, okay? It can be any abnormality. This kid or this neonate may be also having some limb malformation, okay? Abnormalities in the extremities. This neonate may also having an abnormality in the skeletal system, mostly along the vertebral column. You can see that that abnormal orientation. Okay, that is a vertebral anomaly. And also, these kids may be having an anal atresia. You can see no anus or anal opening. That is anal atresia. So whenever you see such cases, you have to continue examining this patient. Of course, this can be seen with your eyes. You can easily see this limb malformation, but you can continue scanning you can take this kid in a scan, and of course sonographically confirm if there is any kidney abnormality. This kid can be taken to echocardiography room to confirm if there is any heart abnormality. You can see this with your naked eye. If it is for the anus is not developed, you can just see this easily, and then X-ray can confirm this vertebral abnormality. Okay, so these are just associated anomalies, and this can be remembered by this acronym for easy remembrance. Okay, so that's what we can talk about regarding the embryology of the esophagus. There are many abnormalities that are related to the esophagus, but that esophageal atresia with a fistula is one of the most common appreciated abnormality clinically. Okay, now let's talk about the esophagus, the gross anatomy of the esophagus. A few things to mention. The length is about 10 inches or 25 centimeters. The width is about 2 centimeters. The lumen of this esophagus is always closed or collapsed whenever you're not swallowing, but when you swallow, it's going to open up. Okay, that's normal. As opposed to the trachea for it never closes. It's never collapsed. It's always patent, but for the esophagus, it can be collapsed when you are not swallowing. The anatomical course. By this we mean how does it, which path does it take within the body? Okay, so if I describe the course of the esophagus, I mean describing the path the esophagus of the esophagus within the body. So basically, you can see that the esophagus is going to begin in the neck region, at the lower border of the cricoid cartilage. You all remember the cricoid cartilage? Okay, that's a cricoid cartilage. Just below that, that's where the esophagus is going to begin from, because above here we have the pharynx. Okay, these are muscles of the pharynx. Hope you remember these muscles. These are muscles of the pharynx. So below the pharynx, at the level of the cricoid cartilage, the esophagus will begin, and it's going to extend downwards in front of the vertebral column to go through the superior mediastinum, then through the posterior mediastinum behind the heart. Okay, then at the level of T10, it's going to pierce the diaphragm and go through the abdomen just a short distance, and then join the stomach. So its course is not complicated, it's almost direct. Okay. Normally, within the esophagus, there are narrowed areas, or they are what we call constrictions. And these constrictions, they are anatomical, they are normal constrictions. Okay. These constrictions are going to be there because of the adjacent structures. Okay, and they should not confuse you for pathological constrictions. Normally, the esophagus can be constricted in cases of disease, but you shouldn't confuse these normal constrictions with the pathological constrictions, as we shall see them later. So, among the esophageal constrictions, you can see that at its commencement, we said it's going to begin from the level of the cricoid cartilage, and just at its commencement, there is a muscle that we call the cricopharyngeus muscle. It's part of the pharynx, and it's going to have circular muscle fibers. These are going to constrict the upper part of the esophagus, and they'll be responsible for that first constriction. So that first constriction, we can call it the pharyngoesophageal constriction. That is going to be as a result of the circular muscle fibers of the cricopharyngeus muscle. Okay. Down along its path, you can see that the esophagus is going to be crossed by the aorta. This is the arch of the aorta. Okay, this is a descending thoracic aorta. So this arch is going to somehow create a constriction in the esophagus at the level of T3 or T4. Okay, this was at the level of C6, but this is at the level of T3, T4. There will be some bit of constriction because of the curving aortic arch. Below that, at the level of T5, around there, we shall have a constriction brought in because of the left main bronchus. So the left main bronchus, of course, you know it's going to be formed after bifurcation of the trachea. Trachea bifurcates to form the right main bronchus and the left main bronchus. The left main bronchus, as it's crossing to go to the left, it's going to cross the esophagus, and it will slightly constrict it. And this constriction will be at the level of T5. Because these two constrictions are almost close to each other, sometimes this constriction is described as one, and we call it the thoracic constriction or the aortobronchial constriction. That's why I said you can describe these constrictions to be either 3 or 4. Okay? You are keen, you can take this as the first constriction at the level of C6. At the level of T4, we have the aortic constriction. At the level of T5, we have the bronchial constriction. but I said you can take these as one and call it the aortobronchial constriction. Then after that constriction, of course, our esophagus descends downwards and pierce the diaphragm, and you know the level of the diaphragm, it's going to be wrapped around by one of the cross of the diaphragm, and that will create another constriction there at the level of T10. Okay, so that will be brought in because of the fibers of the diaphragm that are going to be wrapping around the distal end of the esophagus. Okay, so of course those are the constrictions. Those are normal narrowed areas of the esophagus. Esophagus is normally narrowed at those spots, and usually at those spots, that's where sometimes swallowed objects can dislodge or can lodge. Let's say if someone also, let's say, ingests a corrosive substance, this corrosive substance can cause injuries at those narrowed areas. Okay, and whenever there is an injury at those narrowed areas, of course, it's going to create what we call strictures. Now, strictures are pathological constrictions. Strictures are abnormal narrowing of the lumen of a particular hollow organ. So once there is, let's say, ingestion of a corrosive substance, it can cause abnormal narrowing of the esophagus, and this narrowing is going to be at those areas where the constrictions are. Okay, then those constrictions also have to be put in mind whenever there is need to pass an instrument into the esophagus. Instruments can be passed into the esophagus, the nasogastric tube, okay, the orogastric tube, the endoscope. All those instruments, they have to be passed through the esophagus, and of course care has to be taken because of the fact that there are constrictions along the path of the esophagus. If someone rigorously passes that instrument into the esophagus, of course it can result into injuries at those narrowed areas. So that's why sometimes can present problems during the passage of those instruments. These constrictions, yes, we've seen the vertebral levels. This first one is at the level of C6, the second one at the level of T4 or T3, the third one at the level of T5, the last one's at the level of T10. Okay, but also it's important to note the distances of these constrictions from the upper incisor teeth. Okay, I don't know, there is someone who is not muting. Asauli Juma, please. Asauli Juma, please. Okay, so I was saying these constrictions, the distances where these constrictions are, they are appreciated and they are measured from the level of the upper incisor teeth. Okay, and that is very, very important because let's say when a patient is opening the mouth and you're trying to insert in a tube, you can easily gauge the distance where those constrictions are going to be found just by measuring from the level of the upper incisor teeth. Okay, that's why these constrictions are described, or the distances of these constrictions where they are appreciated from the level of the upper incisor teeth. So from the level of the upper incisor teeth, the first constriction is at it's around 16 centimeters from the level of the upper incisor teeth. The second constriction, or if you take this as one, the thoracic constrictions at the level of it's about 23 to 25 centimeters from the level of the upper incisor teeth. Then the last constriction, where the esophagus passes through the diaphragm, This is around 38 centimeters from the level of the upper incisive. So the relevance of knowing the distances from the level of the upper incisive is appreciated during when there is need of inserting these instruments into the esophagus. Okay, so he said a nasogastric tube can be passed through the nose, down the throat, then down along the esophagus. The orogastric tube can be passed through the mouth, through the throat, and down through the esophagus. These are usually always used, for example, when there is need to drain excess gastric contents from the stomach, or when there is need to clean the stomach, for example, in patients who have experienced poisoning. Okay, so gastric lavage can be done to clean the stomach. Also, this can be used, for example, when the patient cannot swallow normally. These tubes can be used to feed the patient. Okay, then we have what we call an endoscope. An endoscope is just a surgical instrument that has got a camera at its end. It's inserted into the mouth, down the throat, through the esophagus, to take pictures of the stomach or the esophagus, so that different conditions can be diagnosed. Okay, so that's why there is need to know those constrictions to prevent injuries along the path of the esophagus. Okay. Radiographically, these constrictions can be seen. Okay, in this image we are seeing only the two constrictions. We are seeing the thoracic constriction here, what we also call the aortobronch or the bronchoaortic constriction. That narrowed area there, it's because of the aorta and the left main bronchus that are adjacent to the esophagus. Then we are seeing another narrowed area here, just at the entrance of the esophagus into the diaphragm or through the diaphragm. That's another normal constriction. Okay. And then there are also pathological constrictions that we shall see later, constrictions that can come in cases of diseases. These are normal constrictions. This esophagus can be appreciated after patient swallowing a barium meal. Barium is just an agent that can easily coat on the walls of the alimentary canal for clear visualization during radiography. So that's why that kind of agent is used to easily visualize that organ visualize the alimentary canal for or during radiographic procedures. Okay, going forward, let's look at the parts of the esophagus. The esophagus has got the cervical parts, thoracic and the abdominal. The cervical part of the esophagus, it's that portion that is going to extend from the level of the cricoid cartilage down to the level of the thoracic inlet. Below the thoracic inlet, we have the thoracic part of the esophagus that will extend up to the level of the diaphragm. Below the diaphragm, that small portion is the abdominal part of the esophagus. Okay, so those are the different portions. This cervical, it's called cervical because it is in the neck. Cervical means neck. This is in the chest. This is in the abdomen. As simple as that. It's important to note or to understand the relations of these different parts of the esophagus. Okay, let's start with the cervical part of the esophagus. The cervical, it is that portion of the esophagus above the thoracic inlet. This is the thoracic inlet. Okay, so that small portion above, it's the cervical part of the esophagus. As I said, it's going to extend from the level of the lower border of the cricoid cartilage to the superior border of the manubrious tenure. You can say to the level of the thoracic inlet. And you can see that, of course, in front of it, we shall have the trachea. This is the trachea, though it's cut, but it's going to be in front of the cervical part of the esophagus. Okay. And posteriorly, of course, you can't see the posterior structures here, but you can see in this image that posteriorly we shall have the vertebral column. And of course, between the bone itself, the bones themselves and the esophagus, there are some prevertebrate soft tissues, muscles and fascia. Okay, muscles covered with fascia. They are in front of they are attached on the vertebral column. So you can start posterior, you have the vertebral column and the associated structures, the muscles and the fascia. Laterally, on either side, we can see that, of course, your esophagus is going to be associated with the lateral lobes of the thyroid gland. Thyroid gland has this median portion and the lateral portions that you can call lobes. Okay, so these lateral lobes are going to be adjacent to the lateral aspect of the esophagus. And this is important because sometimes this gland can enlarge posteriorly, and once it enlarges posteriorly, it can easily cause partial obstruction of the esophagus. That's why sometimes patients with goiter, patients with thyroid masses can tend to present with swallowing difficulties because this gland can enlarge and partially obstruct or compress the esophagus. Laterally, you can also see that, of course, we shall have the common carotid arteries. This is the right, it's going to ascend. This is the left, it's going to also ascend to be on either. They are going to be on either side of the cervical part of the esophagus. Then there are some associated nerves. You can see the recurrent laryngeal nerves. Who can remind us these nerves? They are branches of what? The recurrent laryngeal nerves. Where do they come from? Anyone who recalls from our session the session where we talked about these, the recurrent laryngeal nerves, they are branches of
vagus nerve.
They are branches of the vagus nerve. So you remember the vagus nerve, that nerve is going to, on the right side, to loop around the right subclavian to give off the right recurrent laryngeal nerve. Then on the left side, it's going to give off a branch that will loop around the arch, aortic arch, and that will extend up to go towards the larynx. All these are recurrent laryngeal nerves. They're going to be also in close relationship with the esophagus. They are anterior, almost anterior to the esophagus, the cervical part of the esophagus. Okay, so there was a question here that I've seen. Someone is asking, can esophageal abnormalities be corrected surgically? Yes. Any congenital abnormality can be corrected surgically. Differences between esophageal constrictions and sphincters. I'll talk about sphincters, but remember we have two sphincters, the upper and the lower. Okay. The cricopharyngeus muscle is going to also be described as the upper esophageal sphincter. We said it brings about that first constriction, but also its circular muscle fibers will form the upper esophageal sphincter that will regulate passage of food substances from the pharynx down to the esophagus. Then David is asking, what about the cervical constriction? Where is it located? The cervical constriction, it is that first constriction brought about by the cricopharyngeus muscle. Okay, David, is that clear?
Yes, it's clear now.
Okay. So sometimes I don't see those questions immediately. I only see them when I leave the full screen. Okay. The thoracic part of the esophagus. This is the portion of the esophagus that is going to be within the chest. So from the level of the thoracic inlet down to the level of the diaphragm, that portion of the esophagus is called the thoracic esophagus, or the thoracic part of the esophagus. There are a few relations, not few, but quite many, but there are many structures in close proximity to this thoracic part of the esophagus. You can see anteriorly, of course, we have the trachea, the right pulmonary artery, that is your pulmonary trunk. The right pulmonary is going to cross the midline just in front of the esophagus to go towards the right lung, okay? The left main or the left principal bronchus, that one there, or this one there, it's going to cross to the left, but to cross while crossing the anterior aspect of the esophagus towards the left lung. Then in front of the esophagus, we also have what we call the left atrium. Let me see. So I'll show you that later. Okay, and there's a very important clinical correlate related to this. The left atrium is going to be among the structures that are going to be anterior to the thoracic part of the esophagus. I'll show you that later. Then posterior, of course, we have the vertebral column, which we can't see here. Okay, then we have the thoracic duct. The thoracic duct, we all know it. This channel, this lymphatic channel in green, carries lymph towards the left venous angle, and it's going to run first to the right side, cross the midline, then run on the left side to pierce the left venous angle. So it can be described as one of the structures that will be situated behind the esophagus. This is your esophagus, so it's running behind it. Okay, the descending thoracic aorta, you can say descending thoracic aorta, in the lower aspect, it's going to cross on the left side by to run towards the midline, or it will shift towards the midline, and as it is shifting towards the midline, it's going to be passing behind, as you can see here. From the left side, it's going to shift to the midline to pass behind the esophagus. It has to run along the midline. Okay. Then we have the right posterior intercostal arteries. These arteries, we know they are going to come from the descending thoracic aorta itself, most of them. And as they are crossing to the right side to supply the right part of the chest, they are going to run behind the esophagus. So that's why we are saying that those arteries, they are going to also be among the posterior relations, so structures behind the thoracic part of the esophagus. On the right side, or laterally on the right, of course, we can see we have the right lung, though you can't see it here, but the right lung and its pleura, okay, they will be on the right side of the azygous vein. We know that vein there, it's going to be draining the right thoracic wall. Posteriorly, it's going to ascend upwards. As it ascends, it's going to run on the right side of the esophagus to come and pierce into the or to pour into the superior vena cava. The right vagus nerve, the vagus nerves, we've talked about them. Here we can see the left, but there's a right. though it's not shown, it's just adjacent to the esophagus on the right side. Then on the left side, of course, we have the left lung and the pleura. The left lung is not shown here, but you can see it's covering. It's going to be almost close to the esophagus. Then the left subclavian artery. The left subclavian artery can be seen here. It's one of the branches of the aortic arch. It's going to come off and run upwards slightly, and then curve to the left upper limb. So it's going to be among the structures that will be on the left side of our esophagus. The thoracic duct. The thoracic duct, we know it. This channel in green here. It's going to be, you can see after crossing the midline, it's going to cross on the left side of the esophagus to come and pierce the left venous angle. The descending thoracic aorta in its upper part, you can see it's going to be on the left side, but we said as it crosses down, it's going to shift from the left to the midline to come within the midline. Okay, so those are structures that are in close proximity to the thoracic part of the esophagus. Here we are seeing a right lateral view of the chest. Of course, the right lung is removed, and you can appreciate that this esophagus is just close to the esophagus. We talked about the different nerves. You can see the right vagus. You can see it there. It's going to cross and come on the right side of the esophagus. This is the right vagus. It's crossing to come down. Okay, so this is just the right lateral view to show you the complex structures in close proximity to the esophagus. Posteriorly, we say the vertebral column. You can see it. That's the vertebral column. Is just behind our esophagus. In front, the trachea, you can see it very well. The left lateral view can also show you the thoracic ducts on the left side. We said that already. But also, most importantly, there is this chamber that we see here. This chamber is the left atrium. Okay, this is the left atrium. The left atrium is anterior to the esophagus. This is the esophagus. It runs downwards, and you can see it here. So your left atrium, it's going to be in front of the esophagus, and that is very important, and it can be further confirmed here. This is your esophagus. It's going to run behind the left atrium. We have the right atrium here where these two vessels are piercing, but also we have the left atrium here where these vessels, the pulmonary veins, are piercing. So your esophagus is going to be behind that left atrium. And that is important, for example, in scenarios when there is, let's say, mitral valve stenosis. We know the mitral valve, it's a valve that allows blood to run from, who can remind us, from which chamber to which chamber? The mitral valve allows blood to run from which chamber to which chamber? Can remind us that? The mitral valve allows blood to run from which chamber to which chamber? Yes, Pearson?
From the left atrium, the left ventricle.
Yes, so in scenarios when that mitral valve is abnormally narrowed, for example, in cases like rheumatic heart disease, there is that condition caused by streptococcus germs or bacteria. That bacteria can attack the mitral valve, inflame it, and result in abnormal narrowing of the mitral valve. So if the mitral valve is narrowed, what will happen? Blood will not smoothly run with ease from the left atrium to the left ventricle. This blood will remain stuck within the left atrium, the volume will increase and the chamber will enlarge. Once the chamber enlarges, that chamber can squeeze, can extend, can enlarge posterior and squeeze the esophagus. Okay, it can squeeze the what? The esophagus. That can also be seen here in this X-ray image. This is your esophagus. After taking a barium meal, that's how it will appear. And you can see in this scenario, it is being squeezed by the enlarging left atrium. Okay, this is the anterior aspect of the image, posterior aspect. Okay, so your left atrium is more posterior, remember? So once it is enlarged, it will squeeze the esophagus, and that complication is called dysphagia megalotriensis. Okay, or you can call it cardiac or cardiovascular dysphagia. This patient is going to present with abnormalities or difficulties in swallowing as a result of enlargement of the left atrium. Okay, enlarged left atrium resulting into abnormalities in or difficulties in swallowing. So that's a complication that can come in if the left atrium expands abnormally in cases of mitral valve stenosis. The abdominal part of the esophagus is it's very small, about 1 to 2 centimeters, very short, and posterior to it we shall have what we can call the right vagal trunk. But to make that clear, I want you to look at this image. Remember, we have the two vagus nerves. We have the right and the left. We say the right is going to run on the right side of the esophagus, the left will run on the left side of the esophagus, but as the left is extending down, it's going to become more anterior. It's going to become more anterior to form what we call the anterior vagal trunk. Okay, and then the right, as it extends down, is going to become more posterior to form the posterior vagal trunk. So posterior, or behind the abdominal part of the esophagus, we can see that we have the posterior vagal trunk, or what some books can call the right gastric nerve, because this nerve is going to the stomach. But to be specific, you can say posterior, or behind the abdominal part of the esophagus, we have the posterior vagal trunk. That is more clear. Then anteriorly, we have the anterior vagal trunk, this one here. The anterior vagal trunk was the left vagus nerve. Okay, but it extends more on the front side of the esophagus to form what we are calling the anterior vagal trunk. So I'll make this clear before sending. Then anteriorly, also we have the left lobe of the liver. This is the liver, the big right lobe and the small left lobe. It's going to be in front of the abdominal part of the esophagus. It's very important when scanning the liver. Okay, the esophagus can be seen when you scan the left lobe. Behind it, the esophagus can be seen running down to the stomach. Okay, so let's look at the histology. Histology is all about studying the tissue structures of an organ. So the tissue layers here, there are 4. The innermost is called the mucosa. This mucosa is made up of which epithelium? Who can tell us? We covered cells and tissues. Who can remind us which epithelium will make up the inner lining of the esophagus and why? Anyone? Yes, Agnes?
It is lined by the non-keratinized stratified squamous epithelium.
Okay, largely it's going to be lined by the non-keratinized stratified squamous epithelium. And what's the function of that stratified squamous epithelium? Why is it there? Agnes? Brian, you are saying? Why is it there? Yes, Godfrey?
It is squamous to easily allow exchange of nutrients, and it is allow
No,
exchange.
no. Umar, Chicha Umar?
It is squamous to provide protection.
It is stratified to provide protection or to prevent wear and tear or abrasion of the esophagus. Remember, your esophagus is going to be allowing swallowing, okay? So those food substances, as they are going down, normally this epithelium has to prevent those food substances from hitting or from injuring the walls of the esophagus. So that's why it is there. It is multi-layered, and it will prevent injury of the deeper structures of the esophagus. Then beneath the mucosa, we have what we call the submucosa, and the submucosa, it's more outer. Okay, to make it clear, this is more inner, this is more outer. As we go out, we have the submucosa, and this submucosa is going to be made up of neurovascular structures, blood vessels and nerves that are going to be innervating these muscles here. Okay, then external to this, we have the muscle layer, what you can call the muscularis propria, or just the muscularis. Of course, this muscle layer has the inner circular fibers and the outer longitudinal fibers. External to that, we have a fibrous layer, which is more external or more outwards. Fibrous layer, what you can call the adventitia, it has more collagen fibers that are going to be protecting your esophagus, but also these fibrous structures are going to connect your esophagus to the surrounding structures of the chest. Okay, and you can say having adventitia. Okay. Yes, I was saying, I'm back, and I was saying that having the adventitia, this fibrous layer, yes, the advantage is it will help your esophagus to be held in position firmly because it has fibers that are going to be extending to attach on the surrounding structures. Okay, but also having this layer, it can easily increase spread of diseases from the surrounding structures to the esophagus, or from the esophagus to the surrounding structures. For example, patients with esophageal cancers, these cancers can easily spread because this tissue layer, it has extensions, or it attaches the surrounding structures in the chest. Okay, so that is the adventitia. It's not serosa. Serosa lines the stomach and other intestinal structures, but the esophagus lined by this adventitia. Okay. This image can further show you the muscle layer Up here we have the pharynx, remember. In front we have the larynx, okay. Below the larynx we have the trachea. Below the pharynx posteriorly we have the esophagus. So we can see that we say that the esophagus is going to be found below the level of the cricoid cartilage. So this is it here. That's the inner circular muscle fibers that are going to be contracting to squeeze the food bolus or the bolus, and then the longitudinal fibers are going to be contracting to allow peristalsis along the path or down the esophagus towards the stomach. Okay. Up here we said we have the cricopharyngeus muscle is going to be the first constricted, the first structure that will result into the first constriction, but also this very muscle is going to contribute to the formation of the upper esophagus sphincter, because whenever it contracts it will limit passage of food from the pharynx to the esophagus, but once it relaxes the food substances can easily leave the pharynx down into the esophagus. Okay, so you can also see that as we said, our esophagus is going to be connected to the surrounding structures, and you can see it here very well. Okay, then in this image you can still see the inner circular muscle fibers, the outer longitudinal fibers. You can see the mucosa. This mucosa is lined by a stratified epithelium. You can see that as we extend down, we are going to see, of course, the mucosa of the stomach. This is lined by a simple columnar epithelium. Okay, and the line that marks the junction between those two epithelial layers, that line is called the Z line. It's going to mark the junction between the esophageal mucosa and the gastric mucosa. Okay, so that is the Z line there. It's very important because normally in patients with gastritis, that inflammation can extend upwards. If it extends upwards, this esophageal mucosal layer is going to be eroded, and the Z line is going to shift upwards. That's a very important feature even radiographically. This Z line here, this line that marks the transition between the esophageal and the gastric mucosa, it can shift upwards in cases of chronic gastritis. There is so much inflammation going on, it can extend upwards and erode the esophageal mucosa. Okay, and this line is going to shift upwards, okay, because of that erosion. So we shall talk about that complication later on. Okay, then another thing that we can appreciate here is that of course the fibers, we've seen them already, the circular muscle fibers, the inner circular muscle fibers, and then the longitudinal muscle fibers, they're going to be continuous downwards with the circular and the longitudinal fibers of the stomach. We shall see that later. Okay. We can also see that along the length of the esophagus, specifically in the upper part, we are going to have striated muscle fibers. In the lower part, we shall have smooth muscle fibers. In the mid portion, there will be a mixture of both the striated and the smooth muscle fibers. The striated muscle fibers, these are the skeletal muscle fibers. Okay, and these muscle fibers can be controlled voluntarily to allow the swallowing reflex to go on. That's why you can initiate swallowing right now. You can swallow right now. You can control it voluntarily right now because of these striated muscle fibers in the upper part of the esophagus. Okay. This image, it can show you that between the inner circular fibers and the outer longitudinal fibers, we have a nerve plexuses, and this nerve plexus is called the myenteric plexus. The plexus between the inner circular and the outer longitudinal muscle fibers. Okay, myenteric plexus. Plexus is a network of nerve fibers in this context here, and myenteric means it's between the muscles of this structure of the gut, this structure that we are calling the esophagus. Okay, then these muscle fibers, of course, their role is to induce contraction of, these nerve fibers, their role is to induce contraction of these fibers here. They can always tell the circular muscle fibers to contract or the longitudinal to contract so that peristalsis can occur along the path of the esophagus, as you can see here. Okay, so those are the special nerve fibers. So you can also call them intrinsic nerve fibers because they are within the wall. They are within the wall of the esophagus. They are within the wall of the esophagus. But these intrinsic nerve fibers, they are always controlled by extrinsic nerve fibers. What are the extrinsic nerve fibers? The extrinsic nerve fibers are those fibers of the autonomic nervous system. The autonomic nervous system is that division of the nervous system that always controls structures that you can't voluntarily control on your own. Right now, you can't sit there and start contracting your heart, your stomach, okay, and then some part of this esophagus you can't make it contract to allow peristalsis to go on. So such structures that we don't have full control over with, they are controlled by the autonomic nervous system, your lungs, your bladder, and many others. And the autonomic nervous system has two components. You have the parasympathetic and the sympathetic. The sympathetic fibers, they are going to be coming off from what we call the sympathetic trunk or the sympathetic chain of ganglia. It is this chain that you see here on the right side and on the left side. So this chain of ganglia or this sympathetic trunk is going to give off sympathetic fibers. Okay. Then your vagus nerves, we have the right and the left. These, you can see the left, it's going to extend down here to form the anterior vagal trunk, and it's going to give off parasympathetic fibers to the esophagus. The right also is going to run behind and give off parasympathetic fibers to the esophagus. So I want someone to tell me what will be the effect of the parasympathetic fibers on the esophagus. What do you think? Anyone to tell us? Let's hear from Agnes.
Parasympathetic nerve fibers, they usually cause, they reduce or they inhibit the process of digestion.
Okay, last time I told you, always the parasympathetic nerve fibers activated whenever your body is at rest. Okay, the sympathetic activated whenever you are under stress. So let me ask this. Will you comfortably swallow when you are at rest or when you are running under stress? Agnes.
Excuse me, I didn't hear the question well.
Swallowing normally occurs when the body is at rest, okay? And just like other processes of the body, urination, defecation, all those body physiological processes have to go on when the body is at rest, and they are controlled by the parasympathetic nerve fibers. So obviously these nerve fibers, they are going to be the nerve fibers that will stimulate the myenteric plexus of nerves to induce contraction of the inner circular and the outer longitudinal muscle fibers so that peristalsis can go on smoothly. But also these very nerve fibers, they are going to induce, we have what we call the submucosal plexus here beneath the inner circular muscle fibers. This submucosal plexus always stimulates the glands in the submucosa to release secretions, because along the esophagus we need some mucus secretions that will allow smooth peristalsis. Okay, that will prevent friction as the bolus is running down along the path of the esophagus. So this will allow swallowing to normally go on. Okay, then these are going to be doing the opposite, because you're not going to be swallowing every time. Every physiological process of the body has to have control. So the sympathetic fibers, they are going to be having the opposite effect. They inhibit contraction of, or to be specific, they are going to inhibit or inactivate the myenteric plexus of nerves so that these muscle fibers don't contract, so that swallowing doesn't go on. And then also they inhibit the submucosal plexus of nerves so that they don't tell the submucosal glands to release mucus secretions. Okay, so in summary, the parasympathetic fibers, they will allow swallowing to smoothly go on, but these, they are going to inhibit the swallowing reflex. As I told you, every physiological process in the body has got a control, and that's how swallowing is going to be controlled. To be specific, we are talking about the esophageal phase of swallowing. Remember, this swallowing reflex or the deglutition reflex has the oral phase, the pharyngeal phase, and now we are specifically talking about the esophageal phase. Okay, and that's how it's controlled. Okay, so the esophagus receives nourishments from several arteries. Of course, remember it's also a body structure. It has its own tissues that makes it up, as we saw in histology. And of course, it should be receiving nourishments from the arteries of the body. To be specific, it's going to receive nourishments from different arteries for different parts of the esophagus. The cervical part is going to be nourished by the esophageal branches from what we call the inferior thyroid artery. This is the inferior thyroid artery. It is a branch of it's a branch that's going to be coming off from the thyrocervical trunk, which is an artery from the subclavian. So the subclavian gives off the thyrocervical trunk, and from the thyrocervical trunk we get the inferior thyroid that's going to give off the esophageal branches that will supply the cervical part of the esophagus. Then the thoracic part of the esophagus is going to be nourished by the esophageal arteries that are going to be coming off directly from the descending thoracic aorta. The descending thoracic aorta has got those direct branches that are going to be going towards the esophagus directly. Then the abdominal part of the esophagus is going to be supplied by the esophageal branches of the left gastric. The left gastric artery, as you hear gastric, it's an artery that's going to be largely supplying the lesser curvature of the stomach. And it's going to be a branch of the left gastric. These esophageal branches are going to be branches of the left gastric, and the left gastric is going to be a branch of the celiac trunk. The celiac trunk is a very short trunk that comes off from the aorta and then divide into three. Divide into this one here that we shall later call the common hepatic artery, and then this one that's going to the left that we shall later learn as the splenic artery, and then this small one that we are calling the left gastric, going to the stomach. Before reaching the stomach, it gives off esophageal branches that are going to come to supply blood to this small abdominal part of the esophagus. The venous drainage can be seen here. The cervical part, obviously, it's going to be drained by the inferior thyroid vein. You can see the inferior thyroid veins, they drain the blood from the cervical part. And this blood eventually is going to enter the brachiocephalic veins on the right and on the left. Then the abdominal, the thoracic portion of the esophagus, you can see it's going to be drained by the azygous system. Remember, last time we learned about the azygous vein, accessory hemiazygous, and then the hemiazygous. So all these three will receive blood from the thoracic part of the esophagus. This is the thoracic part of the esophagus. There are very many networks of veins that you can call the submucosal venous veins, and these are going to be pouring the blood into the azygous system. Some of these veins are going to enter the accessory hemiazygous, some are going to enter the hemiazygous, others are going to enter into the what? Into the azygous itself. Okay. Then we have the abdominal portion. This is going to be drained by the left gastric vein. Remember, it was supplied by the left gastric artery, so obviously it's going to be drained by the left gastric vein. The left gastric vein, it's a vein that's going to later pour blood into the portal vein. The portal vein, as you can see here, the hepatic portal vein, it's a vein that picks blood from your gut, blood that has nutrients, and it will be taking that blood to the liver. So among the veins that join the portal vein, we have the left gastric here, picking blood from the lesser curvature of the stomach, but also from the abdominal part of the esophagus. Normally, the tributaries of the left gastric, they are going to join they are going to anastomose with these esophageal veins that are supposed to drain into the azygous. There will be that anastomosis. It's normal. That anastomosis is one of the portosystemic anastomosis in the body. Last time we talked about the portosystemic anastomosis. I told you that it's normal for the systemic veins to join with the tributaries of the portal vein to form the portosystemic anastomosis. It can be helpful sometimes, okay, to create a collateral pathway for blood. For example, let's just imagine if the left gastric is obstructed, for example, blood can just go through this anastomosis towards the azygous system, okay? But the only problem will arise, let's say, when a patient has got liver disease. The patient has liver disease, as we explained last time, there will be obstruction of the blood channels in the liver, and as those blood channels are obstructed, blood is going to tend to flow in a retrograde fashion backwards into the portal vein. After blood filling the portal vein, this blood is going to go back to where it came from. We've seen that the portal vein is going to receive from many structures of the abdomen. Some of the blood comes from the spleen, some from the small intestine, some from the large intestine, some from the abdominal wall, if you remember, And whenever there is liver disease, this vein is going to be filled with a lot of blood, and some blood can enter the left gastric. Okay, it can enter the left gastric. After entering the left gastric, this blood can fill the submucosal veins, these veins here that are underneath the submucosa. They can be filled, they can be enlarged, and once they are enlarged, of course, we form what we call esophageal varices. Okay, varices are just swollen, enlarged veins. So we shall have esophageal varices because of the veins that are enlarged. As you can see here in this image, the veins are enlarged, and these enlargements can be seen on endoscopy. Let's say when an endoscope is used to look into the esophagus, this is what will be seen. You can see the mucosa is raised because of the underlying enlarged submucosal veins. They are enlarged, resulting into what we call esophageal varices. These enlarged veins can rupture anytime and result into what we call hematemesis. Hematemesis means vomiting of blood. Okay, so all this can happen because of liver disease. Okay, so patients with liver disease can present with esophageal varices, as you can see, and these varices can rupture, resulting into hematemesis. These varices are forming because of the portal systemic anastomosis. Anastomosis between these tributaries of the portal vein and these tributaries of the systemic vein, the vein that we call the inferior vena cava. This is a systemic vein, drains blood from different body systems. That's why I'm calling these systemic veins. And this anastomosis will be called portal systemic anastomosis. Because of that anastomosis, such complications can arise. But I said on the positive side, this anastomosis can sometimes help to provide a collateral pathway for blood. But in disease states, this anastomosis can really result into complications, as we can see here. The lymphatic drainage of the esophagus is complex also. The cervical part will be drained by the deep cervical lymph nodes. Deep cervical. Cervical means neck. So these are lymph nodes deep within the neck. Okay, and they are lymph nodes that are going to be running along the path of the internal jugular vein. So from the cervical part, lymph is going to be drained into the deep cervical lymph nodes. Then from the abdominal or from the thoracic part, lymph is going to enter into what we call the posterior mediastinal nodes. These lymph nodes in the posterior mediastinum. Then the abdominal portion is going to be drained by the left gastric nodes. Okay, these are the left gastric nodes. These left gastric nodes will eventually, of course, also connect to the celiac nodes. From the celiac nodes, lymph enters the cisterna chyli, then into the thoracic duct. This duct here that will later come upwards to join the venous system in such a manner. Okay, so that's the lymphatic drainage, just simple as that. But also, I told you always structures with complex lymphatic networks, complex veins, venous systems, as you can see here. Such structures are going to usually result into easy spread of cancers. Let's say if the esophagus is having some cancer, let's say the adenocarcinomas in the esophagus, those cancers can easily spread because of the complex networks of veins, but also the complex lymphatic channels. Okay, so such patients with such types of cancers always have a bad prognosis. They can rarely survive those cancers. Okay, going on, there is what we call GAD. GERD is a gastroesophageal reflux disease. This happens usually because of dysfunction of the lower esophageal sphincter. This sphincter is supposed to always close to prevent acidic contents in the stomach from propelling or from going back upwards into the esophagus. But sometimes this sphincter can become weak. In most cases, for example, if someone overtakes so much food, so much stomach acid be produced, and this too much acid can irritate the sphincter and result into relaxation of the sphincter. Okay, that's why if you ever take so much food and have a bad sleeping posture, you can always feel some heartburn at night. Okay, that's GERD occurring because of the too much intake of food, and also a sleeping posture. All those can determine, can bring it up, can bring up this condition here. Then also patients with peptic ulcer disease. If a patient has peptic ulcer disease, obviously always there will be so much acid in the stomach, and that acid always weaken this sphincter, and that's why those patients always complain of heartburns. Okay, so it's a condition that usually occurs in most cases in ulcer patients, but also in normal patient without ulcers. If you overeat, if you take carbonated fluids, too much soda, okay, all those can increase the hyperacidity, and you can have heartburn even though you don't have ulcers. So gastroesophageal reflux disease, we said it's going to be associated with the reflux of acidic contents into the esophagus. Usually whenever acidic contents rush into the esophagus, they can cause inflammation of the esophagus, and we said it can result into this ongoing inflammation can easily result into formation of strictures. Strictures, they are abnormal narrowings, okay, that are created in disease scenarios. Okay, so because of the ongoing inflammation, this affected area can contract, as you can see, or what we call cicatrization, can contract to result into abnormal narrowing, or what we call a stricture. These strictures can be seen. There's a stricture there, and you can see another stricture here. Those abnormal narrowings, usually they form because of the long-standing cases of gastroesophageal reflux disease. Usually those patients with GERD can be given medications that can reduce the hyperacidity to prevent complications of GERD, but without medications, of course, such complications can easily arise. Okay. Also, long-standing cases of GERD can result into erosion of the esophageal mucosa. As I told you, that mucosa can be eroded and be replaced by the stomach mucosa, the gastric mucosa. We say that the esophagus is lined by the stratified squamous epithelium, and the stomach is lined by the simple columnar epithelium. So in cases of long-standing cases of GERD, the acidic contents can burn or can injure the esophageal mucosa, and over time the esophagus can be replaced by the gastric mucosa, because we know that the gastric mucosa naturally can withstand the acidity. So over time that replacement can go on in cases of long-standing cases of GERD, and we call that intestinal metaplasia. Okay, Metaplasia means replacement or transformation of replacement of an epithelium with another, as simple as that. Okay, the esophageal epithelium or mucosa is replaced by the gastric epithelium. And of course, such scenarios can predispose to cancer, esophageal cancer, esophageal adenocarcinoma, okay, because of the ongoing inflammation that is not being managed. That complication is called Barrett esophagus, okay. That complication of intestinal metaplasia is called Barrett esophagus, and it can predispose to, it can be precursor for esophageal cancer. Okay, so I said ongoing or long-standing cases of GERD can result into erosion of the esophageal mucosa, and that erosion can be seen in this radiograph. This is the lower or the distal esophagus being eroded. You can see that erosion there of the esophageal mucosa. That erosion, most cases, occurs because of the long-standing cases of gastroesophageal reflux disease. Okay, then there is what we call achalasia. Achalasia is a condition that occurs because of the loss of the myenteric neurons. Let me first take you back here. Remember, we talked about the myenteric plexus. If you remember, the myenteric plexus of nerves made up of small neurons that are going to be always innervating these muscle fibers to allow peristalsis or movement of the bolus. So in some patients, some people are born with less myenteric neurons, or it can be autoimmune. Your own immune system can mistakenly attack these neurons. If they are attacked, of course, it means that specific part of the body that has got these neurons will never easily contract to allow peristalsis. Okay, so such cases happen mostly in the distal aspect of the esophagus, and with the loss of such neurons, obviously peristalsis is going to be hard. You can see over time the upper part of the esophagus is going to widen because the food contents are overfilling it. Okay, and then the lower part is narrowed, abnormally narrowed, without allowing any contents to pass and enter the stomach. So that abnormal narrowing creates a narrow slit channel that appears like a bird's beak. That's why this is called a bird beak appearance. This is always pathognomic for achalasia. Whereas whenever you see such a narrowed distal aspect of the esophagus, always that's a conclusion that this patient is suffering from achalasia. Okay, there's going to be abnormality or problems or difficulties in swallowing, pain when someone is swallowing, that is odynophagia, and also, of course, because of the increased pressure here, the contents here are going to easily, the chances of these contents being brought back, or the chances of regurgitation, is going to be very, very high in these patients with achalasia. Okay, so that is all about esophagus. So time will be enough for us to also talk about the stomach, but I think time wasn't enough. That can be all for today. And when we meet again tomorrow, we shall hear and talk about the stomach. Okay, so yes, Benson.
Okay, thank you, sir. My question is, I'm taking you back like on the other abnormalities of the esophagus. There is where we talked about the Zegas diverticulum in pharynx, can it also happen to the esophagus? Can it also extend to the esophagus also?
The Zegas diverticulum, it's strictly only occurs in the pharynx, because as you've seen along the path of the esophagus, there are no weak spots here. Okay, these muscles are continuous all through, there are no weak spots, but in the lower part of the pharynx, we say that there is a weak spot somewhere. Okay, there's a weak spot somewhere between the fibers that make up the inferior constrictor muscle. So there's that weak spot. There's that zone of sparse muscle fibers or less muscle fibers. Okay, that weak spot there that we call the Killian's dehiscency. That weak spot, we say it results into Zenker's diverticulum, and that condition is strictly only occurs along the posterior wall of the pharynx, because that's where the weak spot is. Okay, it won't extend down in the esophagus. Is it clear to you?
Yes, sir.
Okay. All right. So that was the coverage on the esophagus. We shall meet again tomorrow in the morning, cover the stomach. And after the stomach, we are going to the intestines. Also read about the intestines. We may cover some parts tomorrow after looking at the stomach, because the stomach is not so that wide. So read about the stomach and the intestines to prepare for our session tomorrow. Okay, so the digestive system, it's as simple as this. It's not so that complicated. Things are quite easy and understandable, and these are things that you already know. I'm just adding a few things that can help you clinically when you start practicing. All right, so let me end there. Let me wish you a good day. Let's meet tomorrow.